Hello everyone, myself Dr. Bandhavya. I would like to thank my senior staff who has given me this opportunity to present the ERAS protocol. So what is ERAS? It is a systematic multimodal perioperative care aiming at reducing the immense surgical stress of the patient and thereby facilitating the early recovery by maintaining the normal physiological function. It is also known as Enhanced Recovery Program, Fast Track Surgery and Accelerated Recovery. It was first described in 1990 by European anesthesiologists and surgeons. Henrik Hallett, who was a gastrointestinal surgeon from Sweden, he first proposed the theory of stress-free analgesia and surgery. Originally started for colorectal surgeries, now extended to other specialties. ERAS Society created in 2001 and first symposium was held in 2003. First consensus protocol was published in 2005, registered as ERAS Society in 2010 in Sweden. So now let us see what is the aims and objectives of ERAS. It mainly aims in decreasing the perioperative complications and length of the hospital stay. And it enhances the return of gut function, resumption of normal activity and better patient satisfaction. This is achieved not by accelerating the discharge but rather by achieving an accelerated postoperative recovery. It has also role in other specialties like pancreatic, gastric, urological, thoracic, vascular and gynecological procedures. It is upcoming for breast and reconstructive surgeries, head and neck cancer surgeries, hepatobiliary and orthopedic procedures. So, why do we need ERAS? As we all know that surgical stress causes release of stress hormones, cytokines, which in turn increases the insulin resistance, thereby causing hyperglycemia. This hyperglycemia causes production of oxygen reactive species, which causes inflammation and it further delays the recovery of the patient. So, to attain ERAS, we need a team like surgeons, anesthesiologists, physiotherapists, nurses, dietitians and stoma therapists and ultimately patient and their family. Now let us discuss about components of Enhanced Recovery Protocol. It is broadly classified into intra-op, peri-op and post-operatively. I will be discussing like pre-operatively the optimization of the chronic illness and counseling of the patient, prehabilitation and pre-op oral carbohydrate preloading, thromboembolism prophylaxis. And perioperatively standardized anesthesia technique, lung ventilation strategy, zero balance approach, maintenance of normothermia and prophylactic for nausea and vomiting. And postoperatively multimodal analgesia, postoperative glycemic control, early postoperative mobilization, early enteral diet and early discharge. Now let us see each component in detail. Coming to preoperative counseling. As we all know that proper counseling will lead to the proper cooperation of the patient intra-op and post-operatively. So it helps in dealing with pain and anxiety and fatigue. It also enhances the patient satisfaction and facilitates the early recovery and discharge. And cessation of smoking. It has a role in reducing the respiratory complications and reduces the local wound complication. Hence, at least 3 to 4 weeks of abstinence from the smoking is recommended. As we all know that alcohol causes many adverse effects like malnutrition, impaired immunity, poor wound healing, impaired coagulation, cardiomyopathy which is leading to arrhythmias. Hence, alcohol cessation is also recommended. Coming to anemia correction. Preoperative anemia leads to postoperative mortality and morbidity. So, in females with HB less than 11 grams and in males HB less than 12 grams are recommended to optimize the anemia. Prehabilitation, it is a multimodal approach which includes exercise program, improved nutrition, education in preceding 6 to 8 weeks of major surgeries. and it helps in exercise tolerance and function capacity of the patient. Coming to preoperative nutrition, as we all know that poor nutrition will affect the surgical outcome, especially in patients with cancer. So immunonutrition is advised to reduce the complications and the stay. It is found that in patients who fast for 2 to 4 hours, the gastric volume is low and pH is higher than in patients fasting for more than 4 hours. So pre-op nutrition is recommended. And pre-op fasting guidelines. As we all know that fasting will increase the in stress and it causes the catabolic response in the body. So ASA recommends 2 hours of fasting for clear liquids and 6 hours of fasting for solids patients who undergo elective procedures. And coming to oral carbohydrate preloading. As carbohydrate will attenuate the endocrine stress response and catabolism and perioperative insulin resistance. It also improves the well-being and reduces the postoperative nausea and vomiting. Any clear carbohydrate beverage with approximately 100 grams of carbohydrate may be used. And avoidance of mechanical bowel preparation. It is avoided because of its adverse effects like dyselectrolytemia, discomfort of the patient and dehydration. Let us discuss about thromboembolism prophylaxis. As we all know that thromboembolism will lead to many complications, hence it has to be prevented by giving at least a single dose of enoxaparin 20 mg one night prior to the surgery along with the compression stockings. It has to be continued till the stay of the patient in the hospital. And during surgical procedures, we can use intermittent pneumatic compression devices. And in patients with low or moderate risk of bleeding, we can use low molecular weight heparin. And fondaparinux is preferred in patients with heparin-induced thrombocytopenia or contraindications to low molecular weight heparin. Patients with high risk of bleeding are recommended to have mechanical prophylaxis like intermittent pneumatic compressions and compression stocking and early mobilization. Hip or knee arthroplasty or hip fracture surgeries or any abdominal or pelvic surgeries, they require a prolonged course of prophylaxis, that is around 28 to 35 days. Let us discuss about antibiotic prophylaxis. A single dose covering aerobic and anaerobic pathogens like first generation cephalosporins or amoxiclavulinic acid should be given at least 60 minutes prior to the skin incision. Additional doses is given to obese patients, prolonged procedures which lasting for more than 4 hours, as procedures involving major blood loss, that is more than 1.5 liters, and longer course of antibiotics is no longer recommended. Coming to pre-anesthetic medication, long-acting sedatives are better avoided as pre-medication. Rather than that, we can give per oral paracetamol 2 hours before the surgery or per oral gabapentin around 300 to 600 mg 2 hours before the surgery. Now let us discuss about intraoperative components. Once the patient is shifted inside the OT, as we connect the basic monitors like ECG, NIBP, pulse oximeter, capnography and temperature monitoring. Along with this, we can use neuromuscular monitoring, BIS, to monitor the awareness as the drugs we use in minimal doses, and invasive hemodynamic monitors can be used in high risk patients or in major procedures. Let us discuss anesthesia technique in detail. As we will be inducing the patient with short-acting opioids like fentanyl, remifentanil for the quick recovery, and IV propofol is preferred because of its antiemetic property and rapid recovery. IV vecuronium or atracurium can be used as a muscle relaxants. Induction agents and technique again depends on the hemodynamic stability of the patient, risk of aspiration and anticipation of difficult airway. Let us know about maintenance of anesthesia. It can be either balanced anesthesia technique or total intravenous anesthesia. Advantages of balanced technique being minimal use of the muscle relaxant, ease of titration and rapid recovery. Nitrous oxide is best avoided in long duration procedures and laparoscopic procedures to avoid the bowel distension and postoperative nausea and vomiting. Coming to inhalational agent, sevoflurane or desflurane is preferred. Opioid doses are minimized because of its adverse effects. Neuromuscular blockades is titrated based on the TOF ratio. Now let us see about total intravenous anesthesia. It is mainly used in high-risk patients who are prone for postoperative nausea and vomiting. IV propofol infusions are given based on BIS, around 75 to 150 microgram per kg per minute. IV remifentanil infusion with propofol in TIVA regimens. Coming to ventilation, lung protective ventilation is preferred to reduce the post-op pulmonary complications like low tidal volume of 5 to 7 ml per kg with PEEP 5 cm of water, and recruited manners can be used when indicated. It is found that eye-inspired oxygen improves the blood flow at the anastomotic site and reduces the risk of wound infections. And surgical approach, as we know that minimally invasive technique or laparoscopic procedures are preferred. If open, transverse incision or a small vertical incision is preferred. Use of NG tube in postoperative period does not prevent the bowel leak or wound access, but it may lead to complications like pneumonia, and hence it is avoided. Coming to fluid administration, it plays a crucial role intraoperatively and postoperatively. Hence, the goal is to maintain the optimal circulatory volume without over or underhydrating the patient by maintaining the zero balance approach. Excessive fluid administration results in poor healing of the intestinal anastomosis and prolonged ileus. Overhydration will lead to rise in the central venous pressure, causing pulmonary or peripheral edema. Fluid therapy is given based on blood loss and maintenance requirements. Hypotension is better treated with vasoconstrictor than with the fluids. Use of esophageal Doppler is recommended in high-risk patients and elderly patients. A balanced salt solution is the ideal fluid in the perioperative period. Here is the table showing goal-directed therapy. Now let us discuss about prevention of hypothermia. As hypothermia has got many problems, most commonly it is encountered in open abdominal procedures. Hypothermia, it not only alters the drug metabolism but also impairs the immunity as adverse effects on coagulation and cardiovascular system. Hypothermia increases the metabolic demand, it increases the wound infection and increases the demand for blood transfusion. It can be prevented through several ways like basic temperature monitoring using esophageal probe or IV fluid warmers or forced air warming devices. Coming to nausea and vomiting prophylaxis, patients with moderate or high risk of PONV according to APFEL risk score should be given antiemetic prophylaxis. Patients with moderate risk can be given either IV dexamethasone 8 mg after induction of anesthesia or 5-HT3 antagonists like ondansetron 4 mg at the end of the surgery. High risk patients require 2 antiemetics during the procedure like dexamethasone and 5-HT3 antagonist or metoclopramide or droperidol. And extubation, it again depends on the type of the surgery and the duration of the anesthesia, though early extubation is recommended according to ERAS. Let us see about postoperative components. It mainly includes postoperative analgesia. As we all know that multimodal approach is the cornerstone of the pain management. Opiates are better avoided because of its adverse effects like gut dysfunction, drowsiness, respiratory depression, nausea and vomiting. Use of epidural anesthesia is recommended in open colorectal surgeries. Paracetamol and NSAIDs are preferred during and after the surgeries to reduce the dose of opioids, helps in the management of the pain after the removal of the epidural catheters. And regional techniques are upcoming like interfacial and truncal blocks. Transverse abdominal spleen block has become popular as an alternative option to wound infiltration or epidural analgesia. Coming to postoperative glycemic control, most of the patients are hyperglycemic during the postoperative period due to surgical stress. Hence, the target blood sugar is maintained between 180 to 200 mg per deciliter. Patient with blood glucose level higher than this range should be treated with insulin therapy. Early postoperative mobilization. Avoidance of the abdominal drains, nasogastric tube, opioids and urinary catheters helps in mobilizing the patient prior. Removal of epidural catheter on second postoperative day to enhance the patient mobilization. Early mobilization decreases both pulmonary and thromboembolic complications. Starting of early enteral diet. As postoperatively, patient develop ileus due to bowel handling intraoperatively or use of opioids or use of excessive crystalloids or due to surgical stress. So there is no benefit in keeping the patient nil per orally postoperatively. Chewing gum and laxatives enhance the gut recovery, hence it is advised. Oral fluid should be started as early as 2 hours postoperatively and increased as tolerated by the patient. Early discharge. Patients are usually ready to go home in 8 to 9 days following major abdominal surgeries. Major concerns are anastomotic leak and stoma independence. Poor ASA grade, old age, postoperative opioid use, regional, rectal and complex surgical procedures are some of the predictors of delayed discharge. So these are the ERAS protocol and the components. Now I would request Dr. Vindhya to speak on ERAS protocol in gastrointestinal procedures. Thank you.
Hello everyone, my name is Dr. Vindhya. Today I will be discussing about ERAS protocols for elective gastrointestinal surgeries. So this consists of preoperative, intraoperative and postoperative protocols. So coming to the preoperative protocol, counseling is done. This counseling helps us to have more patient involvement in the protocol, and it helps us to reduce the anxiety of the patient. Then smoking, alcohol and other addictive drugs are stopped 4 to 6 weeks before to the surgery. Then optimization of comorbidities is done preoperatively. Pre-medications in the form of sedatives or longer acting anxiolytics are avoided. Venous thromboembolism and antibiotic prophylaxis is given in all patients. Coming to bowel preparation, it is not routinely recommended in all GI surgeries. It is recommended in patients who are undergoing left-sided colonic surgeries and in patients with low anterior resection of colon. So when bowel preparations are to be done, mechanical bowel preparations are preferred over hyperosmolar bowel preparations, and these mechanical bowel preparations are combined with oral antibiotics. So coming to the preoperative fasting. Solid foods have to be stopped 6 hours before to the procedure, and a patient is asked to take a carbohydrate rich drink around 800 ml the night before the surgery and 400 ml of the same drink 2 hours before the surgery. This has shown that the residual volume which was found in the patients who have fasted overnight is almost similar to the residual volume in patients who have had a carbohydrate rich drink 2 hours before to the surgery. Coming to intraoperative, the protocol can be surgical related or anesthesia related or general considerations. So in general considerations, it involves the antimicrobial prophylaxis. If a patient is at high risk of infection, then antimicrobial prophylaxis is start from the day before the surgery in the form of at least a single dose of antibiotic has to be given the night before the surgery. And in all patients, antibiotics have to be given 60 minutes before to the skin incision. Coming to the surgical considerations, minimally invasive surgeries are preferred over open procedures. And when open procedures are planned, it has to be a single transverse, smaller transverse incisions instead of a vertical incision. Catheters have to be removed early in the postoperative period, and drains are to be avoided whenever possible in the intraoperative period. Then anesthesia related considerations, anesthesia protocol has already been discussed by Dr. Bandhavya. Coming to analgesia, it is multimodal analgesia which is preferred in these patients. It can be started before the induction of the patient, that is preoperatively we can start the analgesia protocol, or intraoperatively it can be given in the form of IV analgesics or in the form of epidural anesthesia or analgesia, or in the form of truncal blocks and interfacial blocks. TAB block has been gaining recent significance in abdominal surgeries. Then PONV prophylaxis, patient with high risk of PONV or with moderate risk of PONV are graded according to the APFL score, and PONV prophylaxis is started intraoperatively. Patients have to have goal directed fluid therapy. This prevents the bowel edema and anastomotic leaks in the postoperative period, and patients' temperature have to be monitored and maintained. Coming to the post-operative period, we avoid fluid overloads, and early resumption of feeds is preferred. And in patients with gastric dysfunction or at risk of gastric dysfunction, based on the IFEED score, the post-operative oral feeds can be started. Early mobilization of the patient is encouraged, and multimodal analgesia and with truncal blocks pain control is done. Coming to conclusion, ERAS is the multidisciplinary team approach in which the surgical team, the anesthesia team, the nursing team as well as the patient play an important role. It starts before the admission of the patient to the hospital and is continued throughout the admission in the preoperative, intraoperative and postoperative phase, and is continued till the discharge of the patient. So this improves the quality of care that the patient receives, the financial stability of the patient is improved, and the survival rates of the patients have improved. And overall the length of the stay of the patient has been decreased, the cost of the treatment which the patient receives has been decreased, and the delays in and cancellations in the surgical procedures are decreased. So in conclusion, ERAS in the gastrointestinal surgeries, in the preoperative period, it is important to give a carbohydrate loading dose. It is important to avoid bowel preparations as and when possible, to give thromboprophylaxis and antibiotic prophylaxis to all patients, and adequate counseling has to be done preoperatively. And intraoperatively, shorter acting anesthetic agents have to be used. Pain has to be controlled either by multimodal analgesia or by epidural or blocks. And overhydration of the patient has to be avoided. Patient has to be kept in euvolemic state and in normothermic state. Then in the postoperative period, pain control is important, and it is done through either epidural or through truncal blocks or through multimodal IV analgesics. Nasogastric tubes have to be avoided. Catheters and drains have to be removed as and when possible. This will be decided. This will be based on the patient and the surgeon. And patients have to be started early on the enteral feeds, and early mobilization is indicated. And if patients cannot be started on oral feeds, then at least gut motility stimulators like chewing gums or laxatives can be given to the patient. And patients, oral nutrition is also important in the postoperative period. The IV fluids have to be stopped as early as possible in the postoperative period. And overall an audit has to be done in which the committee decides about how exactly the protocols can be modified and for the better outcome of the patient. These are our references. Thank you. I would like to thank all my seniors for giving me this opportunity.